my name is Steve Jurch, and I'm the Director of Massage Therapy for the Women's Tennis Association, and I teach continuing education through Jurch Performance Education. And I'm here today at Oakworks, working with Nate here, and I want to pass along some sports massage techniques that I've utilized over my career. And we're working today with one of Oakworks' premier sports massage tables, which is the Boss. It's fantastic, especially if you travel or work with athletes. And so what I want to talk about now is it is a common condition that we see in massage therapy, but it's not necessarily well defined, and that's sacroiliac joint dysfunction. And if you recall, the sacroiliac joint is the joint between the sacrum and both iliums. And the job of the SI joint, or the pelvic ring as they are collectively called, is to absorb shock from the lower extremities. It's to create the link between the upper body and lower body. And if there is an imbalance in that pelvic ring, whether it's from a traumatic fall or muscle imbalance that's pulling on one side of the pelvis, or a lot of times you see it after pregnancy. Sometimes you see it from a low back injury that can cause muscle dysfunction in other areas, and that just relates into the SI joint. So although assessing it is different for everybody, some of the symptoms are very clear for this condition. And what you'll see is same-sided gluteal pain. You will see pain over the SI joint that's affected, and a lot of times you'll get a little nodule over that SI joint or the PSIS, posterior superior iliac spine. You'll sometimes get some radiating into the hip and sometimes down the leg. And so a lot of times this is misdiagnosed as potentially a lumbar spine injury or a disc problem. And so you definitely want to rule those out. But you also want to perform some assessments to help guide your treatment if you suspect that it might be sacroiliac joint dysfunction. And so we're going to do a couple of orthopedic assessments now, and we want to be really conscious about how we utilize the information. So we're utilizing these tests in order to gather information to guide our treatment. We're not making a diagnosis. We're not doing an evaluation because those are outside our scope of practice. So you just want to be very careful how you utilize this information. And the first test we want to do is called Gillett's test, and we're looking for that movement in the sacroiliac joint. So if you'll just turn, that's right about there. Okay, so how we do this test, we're looking for the landmarks, which are the PSIS. So typically what we see are these dimples in the lumbar spine. Okay, and so this test we're just assessing to see if it's moving or not. And so we want to put our thumbs on the PSIS. And what we're going to do is I'm going to have Nate flex his leg. So pick this leg up for me. And back down. And do the other side. Okay, and back down. And you saw when he did that, watch my thumbs. Do it one more time. And you see my thumb drop and back down. And do the other side again. And you see the other thumb drop as well. Now, if there was a dysfunction at this joint or he was having pain, he typically would present with pain right over the PSIS. Sometimes it would radiate into the glute. But he would also, that thumb would not necessarily move at all. So as he picked his leg up, my thumb would stay right where it is. And that's indicative of a hypomobile joint. And so that, to me, would be a positive test if there's not a lot of movement. Okay? The next test is called Gainsland's test. And so what I'm going to have him do is kind of sit on the edge of the table. You want one leg to end up hanging off the side of the table. And so what we're going to have him do is he's going to grab his thigh, and as he grabs his thigh, he's going to roll back and just let this leg hang off the side. Go ahead and do that. Now, he's going to pull his thigh up to his chest, and then you're going to apply a little bit of pressure to that thigh that's hanging off the edge. This is almost like a stretch for the quads, but what you're looking for is pain in that PSIS area or the SI joint. And if he has pain in that SI joint, that's a positive test. Okay, come back up. Now, with these tests, we don't want to just use the results of the individual test to make that treatment decision. What we want to do is look at the whole picture. So you're looking at the history, any observations, any palpations that you've done on that to kind of take that global approach to decide whether, yes, I'm going to treat him, or maybe he should go see another healthcare practitioner prior to coming back, and those types of decisions. Okay, when we treat sacroiliac joint dysfunction, there are a couple key areas that we want to focus on. And for completeness, I would have released the erector spinae, quadratus lumborum, the gluteals, specifically glute medius, and piriformis, and some of the other rotators. But I want to focus on some of the areas that are not as commonly treated with sacroiliac joint dysfunction, but are extremely effective. And the first one is the iliopsoas. And the landmarks that we're going to look for iliopsoas are the ASIS, anterior superior iliac spine, and the umbilicus or belly button. And we want to stay lateral to the rectus abdominis. And once you get above the umbilicus, you kind of run into some solid organs, so we actually don't necessarily treat up past the belly button. And we're going to focus on the two different aspects of that muscle. And actually with SI joint problems, the iliacus has more of a direct effect than the psoas portion of the muscle. And so how I tend to work on iliopsoas is I once again utilize a lot of active techniques. And so we've warmed up his abdomen. And so how I start is I start at the ASIS, and then I'm going to have him take a deep breath, and as he exhales, I'm going to direct my pressure along the inside of the ilium, so scoop into the bowl, sometimes it's referred to. And then once I find a tight area, I'm going to direct my pressure back towards the ilium. So I'm going to use the ilium to push into. And what I'm going to look for is once he starts, and then I'm going to have him actively move his leg, and then I'm going to look for tight areas. So take a deep breath for me. And as he exhales, I slowly slide into the bowl. And once I find a tight area, my pressure is back towards the ilium. So as he's breathing, I'm assessing the condition of the tissue, and then I'm going to have him slowly extend and flex that leg for me. So go ahead and slide it down. So his heel is staying on the table. He's sliding that leg, extending that thigh, and flexing the thigh. Keep doing that for me. So as he moves, the muscle contracts and it pushes up into my hand, and I can feel where the tension is. So I adjust my direction. So if I need to adjust it towards this portion of the ilium or more inferiorly, it just depends on the person. Okay, and relax at the top. So he's relaxed. Now when you change position of your hand, if I want to work more on the psoas, I need to move my hand. But first, I need to take it out. I just don't want to lift my hand off the client. It's too disruptive. So I just slowly bring my hand out. And a lot of times people forget that, and it's quite a shock to the client. Okay? So that's iliacus. Now if I want to move into the psoas, I'll start at that same position. Take a deep breath for me. And then this time, I'm going to scoop in, but I'm moving more towards that belly button, and actually the direction of pressure once I find a tight spot is down towards the table. So I'm moving along the spine now. Once I find that spot, I can just hold it. Go ahead and slide for me. And once again, I'm looking for that tight area to push into my hand to direct where I need to go. So I'll have him do this one more time. And you don't necessarily want to spend a whole lot of time in here just because it can be uncomfortable for the client. It's not an area that's worked a whole lot. One more time. And so sometimes it can be, you want to take it easy with your clients. Okay, and relax. And once again, I'm just going to relax and come out. Okay, and then we can do some smoothing strokes. Now, with the psoas, I utilize active movement just because it gives the client control over the level of discomfort or of the pace of the stroke, and so it really puts them in control. And so it's what I found one of the most comfortable methods of working on this particular muscle. Okay, another area that you can address when working on or when treating sacroiliac joint dysfunction is the adductors. This area, if you think about one of the reasons SI joint dysfunction occurs, is a pelvic imbalance. So we've got some muscles that are pulling harder than others on one side versus the other, and so that's going to misalign that joint. It's going to prevent the joint from moving properly. And so one of the key areas is the adductors. And we can address the proximal attachments from the supine position, but in the sideline position, we actually can really get into the belly and more of the distal attachments. And so this is one of the areas. And then the next area we're going to work on is actually obturator internus. Okay, so for the adductors in this position, you can see that they're facing straight up. So we have a nice flat surface to press into. A lot of times when you work the adductors from the supine position, the client feels like they have to hold their leg up, and so they're actually contracting the muscle at the same time you're working on it. Whereas in the sideline position, we're dealing more with that total relaxation of the area. So we can really get into the adductors. And once again, this is an area that's typically not addressed, and so it could be uncomfortable for your client. So just maintain that, just be aware of that level of comfort. Okay. You can also address that medial hamstring semimembranosus in this position as well. So we can really get into those distal attachments. We can do some really good strokes through here and address those adductors. This is also a great position to work adductor magnus because it sits beneath all the others, and so you can go through the other muscles to get to it. All right, the last area we want to address is actually the obturator internus. And when working that area, we want to look for the landmark, the ischial tuberosity. Okay, so what we're going to do is we're going to trace up the hamstrings, find the ischial tuberosity. So if this is the ischial tuberosity, we're going to be on the medial side, and we're just going to go up and over the medial or the ischial tuberosity, right onto the obturator internus. And that muscle is really good at releasing the entire pelvis, which will free up that SI joint. Okay, so we're just going to trace up the medial hamstring. We're going to find that ischial tuberosity, which is where the hamstrings originate from. And then all we're going to do is just kind of follow that bone up and over, and you don't have to go very far. And then the direction of pressure is down onto the table. And all we're doing, we're not doing any movement with this, we're just holding that position. And so it's almost a little bit of a fascial release, and you can work right through the clothes. And you're just waiting for that muscle to let go. So those three areas, the iliopsoas, the adductors, and the obturator internus, in combination with releasing the other tissues I mentioned earlier, very effective at restoring normal movement and balance to the pelvis and to the SI joint. Really helps this condition. I'd really like to thank Oakworks for putting these videos together. I'm very passionate about massage education, and I think these are great tools for therapists. I have some really interesting things on my website, and I'd love for you to check it out at www.jurchperformanceeducation.com. Thanks, and I hope to see you soon.